Arteriosclerosis is the thickening or hardening of the arterial wall, often associated with aging and hypertension. Atherosclerosis is a type of arteriosclerosis involving the formation of plaques within the arterial wall, and this is the leading factor for cardiovascular disease. And here's just a nice picture where it's showing the formation of those lipid material plaques for the atherosclerosis, and then the arteriosclerosis is just the thickening of the walls. Again, this is all patho. So what do we do for these patients? Again, I think we've talked a lot about it. It's the same as everything else. It's that smoking cessation, weight management, exercise. Okay, I stumbled a little bit there, but it's the same lifestyle changes we've talked about with the other vascular diseases. The medications that are used are statins to help to lower that cholesterol level. You'll see that as well as other lipid-lowering agents. Some people take the niacin and the Lovison as well. Again, you've had pharmacology, so it's just important to know what medications are used to help to lower that cholesterol level. Peripheral artery disease. It alters the natural flow of blood through the arteries and veins in peripheral circulation. Chart 36.3 talks about the key features of chronic peripheral artery disease. That is on page 732 and is extremely important. It's a pretty blue color right underneath a very nice figure 36.3 that talks about locations of inflow and outflow lesions. Both of those would be important to look at. Peripheral vascular disease implies the arterial disease. However, some patients do have both. And those chronic peripheral artery diseases that we're looking at, arterial disease, stage 1 is asymptomatic, but they probably will have decreased pedal pulses, or the pedal pulses may be absent or only palpable through a Doppler. With the claudication, you'll start seeing muscle spasms and cramping and burning with exercise, and is relieved with rest. Symptoms are reproducible with exercise. Resting pain is pain while resting, commonly awakens the patient at night. The pain is decreased by numbness and burning. It's just a nagging pain. And then that last stage is necrosis and gangrene, where you start having ulcers and blackening of the tissue, usually starting at the toe or the forefoot, or sometimes on the heel. And the distinct gangrenous odor is present with the gaseous gangrene. Nursing interventions include teaching the patients not to cross their legs or to wear constrictive clothing, including like garters to hold up hose. Sometimes older women will still use those at times. You want to make sure that they're keeping a warm environment and that they're taking their medications as prescribed, including their aspirins. And I want to make sure you take a minute to look at the key features and differences of lower extremity ulcers, from arterial ulcers and venous ulcers, especially on page 734, chart 36.4 talks about the difference between the arterial ulcers and venous ulcers. That's a really good representation of being able to tell the difference of the two. When medication is not effective, there is surgical options, including invasive procedures such as where they will actually place stents in the legs to help to restore the pulses. They also sometimes will have to do a surgical procedure called the arterial revascularization. In this case, it's very important, actually with both procedures, they're going to mark where the pulses were found, and they'll tell the nurse has to report if it was found with Doppler or if you were able to feel it. And it is imperative that if that changes, that you let the provider know immediately, whether it goes from where you could hear it with the Doppler to where you can't hear it, or if it goes to where you have to now look for it with the Doppler. Again, I feel like you can read through the physical assessment. It's really just a different breakdown of the talking about the chronic peripheral artery arterial disease. Key features that are on chart 36.3, and that's very important to look at. Also, the chart on 36.5, talking about the home care of the patient with peripheral vascular disease, and the chart 36.6, talking about the foot care on page 737. Those are all good things to look at just to get an idea of how we can care for these patients. These ulcers are different from diabetic ulcers. A lot of times diabetic ulcers, the patients don't feel pain. These start out as small, round punch outs, and they're very painful. So that's one of the big differences between it and a diabetic ulcer. You generally will have trouble finding pulses below the site where the ulcer is. But it's important to look for, even if you can't feel a pulse, you need to make sure that you listen with a Doppler as well to verify. And if you can't find a pulse at all and it's not been documented before, then you need to make sure that the provider is aware. Nursing interventions include making sure the patient is exercising, making sure that they're not crossing their legs, make sure that they are on a smoking cessation program, they're taking their medications, they're controlling their hypertension. All of these things are important to assist in the care of this patient. Like I spoke earlier, sometimes the patient does require surgery, which is the arterial revascularization. They try to use their own graft if possible. Post-operatively, it's very important to make sure you keep an eye on that pulse. It's monitored very quickly. We make sure that we're doing that turn, cough, and deep breathe. Make sure that we monitor for compartment syndrome, making sure that it's not swelling, that you have a good pulse, that it has good blood flow, that the extremity is warm to touch, that if they were able to wiggle their toes, they can wiggle their toes, and that we're assessing for signs of infection as well. Really quickly, I just want to introduce you to the acute peripheral arterial occlusion. This is usually caused by an embolus. It is a medical emergency, sometimes surgical. It may affect an upper extremity, but it's most commonly seen in lower extremities. You look for the 6 P's of ischemia: the pain, pallor, the pulselessness. They're unable to move it, and they also will have coolness, or it'll have a cold feeling as well. And this is again, emergency. A lot of times they will take them to the OR to try to revascularize, or to interventional radiology and place a stent, which is a lot of times what they'll do if it's an emergency, because it's less invasive, and they can do that procedure quicker. Berger's disease is seen a lot of time with smokers. It's claudication in the feet, lower extremities. They have an increased sensitivity to cold. Sometimes you'll see ulcerative gangrene to the digits. The cause is unknown, but it is associated with smoking. Renal's phenomenon is caused by painful vasospasms of the arterioles and arteries of the upper and lower extremities. Sometimes they will use procardia for that. You try to restrict their cold exposure and reinforce education to the patients. A lot of times these patients will wear gloves inside. A lot of times they will have more trouble with this during times of stress. But sometimes they will place them on medication to help with it. Venous thrombosis. Deep vein thrombosis is the most common type of thrombophlebitis. It is the cause is truly unknown, but it is associated with Victros's triad, which is where you have stasis of blood flow, endothelial injury, and or hypocoagulability. These lead to, um, we do know that there are some predisposing factors that can lead to deep vein thrombosis, including multiple different kinds of surgeries, such as hip surgery or knee surgery. They also have determined that oral contraceptives can increase your risk of deep vein thrombosis as well. Other people who are at risk for deep vein thrombosis are people who sit a lot, who are on airplane rides. All those can lead to the deep vein thrombosis. People who have been placed on bed rest or have been immobile due to surgery. That's the reason they'll use compression stockings um, or STD hose to help to prevent venous thrombosis. The core measure set on page 742, table 36.8, goes through the core measures required to prevent venous thrombosis while in the hospital and immediate post-op. Um, if the patient is suspected of having a deep vein thrombosis, they sometimes will have pain in their calf or groin. The leg may swell unilaterally. We no longer check for Homan's sign. They can also just have localized edema. Sometimes you'll even see some red streaking. Um, the way they will diagnose that is either through a venous ultrasound. They will look for elevated D-dimers by lab work. Here you see the non-surgical management. They'll um, elevate the extremity. They'll use compression stockings or STDs. They'll either use a heparin drip or low molecular weight heparin, such as Indaprin. Sometimes the patient will go home or be placed on warfarin. And sometimes they will use thrombolytics if they feel as though that they can burst that clot, but that's not, normally they will just try to use the heparin and the compression stockings. Venous insufficiency results from prolonged venous hypertension that stretches veins and damages the valves. Over time, stasis dermis, which is a red browning of the discoloration along the ankles and extending up the calf. And this can also lead to venous stasis ulcers formation. The goal is to decrease edema and to promote venous return. These patients will benefit from not only controlling their hypertension, but also making sure that they wear some type of compression stocking. And here is some very severe insufficiency. It's usually just, you start seeing it more just a light brownish color, and it's sometimes improved by wearing the compression stockings or elevating the extremity. And that's also a venous ulcer on the other side there. And here is where they talk more about the non-surgical management of the ulcer to the venous ulcer. And also, they kind of mush the two together here. It also talks about the venous insufficiency as well. Again, we've already talked about that they should wear compression stockings and they should elevate the extremity as much as possible. And lastly, varicose veins. The goal with varicose veins is to improve and maintain optimal venous return to both the heart and to prevent progression. Nursing interventions are to encourage the use of elastic stockings or compression hose to make sure they elevate the extremity for exercise. Interventions that can be done is the sclerotherapy. They can have surgical removal of the vein, and they also can have laser treatments to the vein.